Hey y'all, my name is Kurtz. I'm a nurse practitioner student at Auburn University, and today we're going to be doing a head-to-toe assessment. I just washed my hands before I came in the room. I have my patient here. Normally she would be in a hospital gown, but for the sake of modesty, she's going to be remaining clothed for today's assessment. I also want to let you know that for any assessments that would be done bilaterally, such as the ears, the eyes, or some of the musculoskeletal exam, we're just going to be doing that on one side to conserve time. Doing a general survey of the patient here, you can see that she is a young adult female. She appears to be healthy, in no acute distress. She is well groomed. She appears to have good hygiene. She's dressed appropriately for today's exam, and I don't smell any obvious odors or anything. Can you please tell me your name?
My name's Sarah.
Where you are?
We are in Denver, Colorado.
What year it is?
It is 2021.
And who the president is?
It is President Biden.
So she is alert and oriented to person, place, time, and situation. So she's ANO times 4. We also took her vital signs and triage, including her blood pressure, heart rate, respiratory rate, oxygen saturation, temperature, and are you in any pain today?
No.
No pain. All of her vital signs are normal. We also took her height and weight as well, and her BMI is within normal limits. Next, we are going to get into assessment of the hair, skin, and nails. So first, you can see her skin. We're going to be assessing this throughout the entire exam, but you can see that her skin is pink, warm, and dry. There's no any obvious lesions, bruises, ulcerations, anything like that. Moving on to her nails. Her nails are strong and without clubbing. If you put your fingers together like that, you can see Shamrock's window right there. There's no clubbing, and her capillary refill is less than 3 seconds. Moving on to her hair, you can see it is soft and thick. It's evenly distributed. I don't see any evidence of lice or anything. And from there, we'll move on to assessment of the head. So I'm going to start by inspecting and palpating her scalp. Her head is normocephalic. I don't feel any indentations, lesions, bumps, bony deformities, anything like that. Then we're going to move down and we're going to palpate and percuss the frontal and maxillary sinuses. Do you feel any tenderness here?
No.
Awesome. From there, we are going to test for cranial nerve 7. That's the facial nerve. You can see that at rest her face is symmetrical, and I'm also going to have her do some movements so we can assess that as well. Can you raise your eyebrows, close your eyes, like squint, smile, frown, puff your cheeks out. So cranial nerve 7 appears to be intact. Next, we're going to palpate the temporomandibular joint. Can you open and close your jaw? You can see I can feel there's no clicking or popping. Can you clench your teeth as well? And this assesses for temporal and masseter muscle strength. That's trigeminal cranial nerve 5. We're going to continue assessing for trigeminal cranial nerve 5 by testing sharp versus dull facial sensation. And have the patient close your eyes and let me know if you feel sharp or dull.
Sharp. Dull. Sharp. Dull.
All right, so cranial nerve 5 appears to be intact. And then lastly for the head, we're going to palpate the lymph nodes and palpate preauricular, parotid, postauricular, occipital, tonsillar, submandibular, submental, anterior cervical chain, posterior cervical chain, and the supraclavicular lymph nodes. You feel any tenderness in any of those areas? No. So there's no tenderness. Her lymph nodes are within normal limits. And then we're going to move on to the eyes. So first for the eyes, I'm going to assess the external eye, including the eyebrows, the eyelashes, the whole area surrounding the eye. You can see there's no redness, drainage, swelling, foreign bodies, anything like that. Then we're going to palpate the lacrimal duct and the orbit area. Do you feel any tenderness there?
No.
There's no tenderness there. And as I said before, there's no drainage. And then we're going to assess for optic cranial nerve 2 and test visual acuity. So I'm going to have Sarah hold the Snellen chart out and cover one eye and read the lowest line that you can read.
LTFPH.
So we would do that on both eyes, and that's the lowest line on the chart. So that means that her visual acuity is 20/20 bilaterally. Then we are going to continue assessing for optic cranial nerve 2. I'll have you stand up. And we'll just go like this, like diagonal. And I'm going to do the confrontation test. So I'll have you cover one eye and then tell me when you can see my hands in the periphery.
I can see them. I can see them. I can see them. I can see them.
And then we would do it on the other side.
I can see them. See them. See them. See them.
Okay, awesome. And then you can sit back down and we're going to test for eye alignment, and extraocular movement. This is cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens. I'm going to have you do the points of gaze test and have you follow this pin. Okay, great. Then we're going to do the cover-uncover test. I'll have you cover one eye and uncover. Cover the other eye and uncover. There's no lateralization of the covered eye, which is a normal finding. And then I'm also going to do the corneal light reflex, so just stare straight ahead. And what I'm looking for here is for the reflection to be symmetrical in both eyes, and it's midline bilaterally, so that's a normal finding. Next thing we're going to do is test for pupillary response. This is optic cranial nerve 2 and oculomotor cranial nerve 3. So look straight ahead. Her pupils are 3 millimeters, equal, round, and reactive to light. And if you can follow this, and they accommodate as well. That's the direct and consensual response. And then we're going to move on to the fundoscopic exam. So for the fundoscopic exam, I am looking to visualize the red reflex as well as the optic disc, the retinal background, the blood vessels of the eye, looking for any narrowing, hemorrhaging. I'm also looking at the macula, the fundus, and the fovea centralis, and I don't see any abnormalities there. So from there, we're going to move on to the ears. The next 3 tests I'm going to do are going to assess for acoustic cranial nerve 8. The first is going to be the whisper test. Actually, I'll have you stand up and stand up right here. And I'm going to have you cover, the other ear. And I'm going to whisper, and I have you repeat what I whisper to you.
Okay.
CD3.
CD3.
Yes, perfect. Okay, you can go ahead and sit back down. And then we're going to do the Weber test, this test for lateralization. I'm going to have you tell me if you can hear the sound equally on both sides.
I can hear it equally.
Okay, and then we're going to do the Rhine test, this test for conductive hearing loss. I'm going to have you let me know if you can stop hearing the sound. I'm placing the tuning fork on the mastoid process.
And I can stop hearing it. I can hear it. I can stop hearing it.
Okay, so air conduction is longer than bone conduction, so that's a normal finding. Next, I'm going to inspect and palpate the auricle. I don't see any redness, swelling, drainage, foreign bodies, anything like that. Then we're going to do the otoscopic exam. I am going to insert my otoscope into the ear canal, and I am looking for the tympanic membrane. I know that I am looking at the tympanic membrane because I can see the long and short process of the malleus. Her tympanic membrane is pearly gray and shiny, and I can see the cone of light at 5 o'clock. So from there, we're going to move on to the nose. First, I'm going to inspect and palpate the nose. It's symmetrical. I don't see any deformities, redness, swelling, drainage, anything like that, including her nares. We're next going to test for patency. I'm going to have you occlude one side and breathe in. And we would do that on both sides. Her nostrils are patent on both sides. And then we are going to assess for olfactory cranial nerve 1. And if you can close your eyes, I'm going to have a familiar scent. And if you can tell me what you smell.
An alcohol pad.
Perfect. So olfactory cranial nerve 1 is intact. And then the next thing we're going to do is we're going to look at the internal nose. I'll have you tilt your head back just a little bit. And I'm going to look at the inside of the nose on both sides. Her mucous membranes are pink and moist, as well as her terminates. There's no edema, and her septum does not appear to be deviated. The next thing I'm going to do is move on to her mouth and throat. First, I'm going to inspect the lips. They are pink and dry. There's no ulcerations, cracking, cyanosis, anything like that. Then I'll have you open, and I am going to inspect the internal structures. I'm looking at the mucous membranes, including the buccal mucosa and the gingiva, both of which are pink and moist. Her tongue does not appear to have any white patches or cracking. She has good oral hygiene. All of her teeth are intact. Her tonsils are +1. Her hypoglossal and, can you lift your tongue for me? Sublingual palate are intact, and her posterior pharynx is without erythema, and her uvula is midline. I'm also going to test now for glossopharyngeal cranial nerve 9, and I'll have you open up and say ah. Perfect. So her uvula rises when she says ah, so that is a normal finding. And then we're going to assess for vagus cranial nerve 10. I'm going to have the patient cough for me. Perfect. So cranial nerve 10 is intact. This is also where we could stimulate her gag reflex, but we're not going to do this for the purposes of today's exam. Next, we're going to test for hypoglossal cranial nerve 12. Can you stick your tongue out for me and move it up, down, side to side? Can you say light, tight, dynamite?
Light, tight, dynamite.
So cranial nerve 12 appears to be intact. You can also hear that she does not appear to have any problems with speech or articulation, and that tests for trigeminal cranial nerve 5, facial cranial nerve 7, vagus cranial nerve 10, and hypoglossal cranial nerve 12. Then we are going to assess the neck. I'm going to inspect and palpate the neck. You can see that her trachea is midline. Then I'm going to have you turn just a little bit. This is fine. And I'm going to palpate her thyroid. I don't feel any goiter or anything. Can you swallow for me? And her thyroid rises with swallowing, which is a normal finding. I'll also assess for accessory cranial nerve 11. I'll have you shrug your shoulders and then turn your head against my hand. We would do that on both sides. She's able to use her accessory muscles against resistance, so that is a normal finding. Cranial nerve 11 is intact. Then we're going to move on to the respiratory system. So you can sit down. The first thing I'm going to do is inspect, so you can see that Sarah has a regular rate and rhythm of breathing. There's no increased work of breathing, accessory muscle use, retractions, anything like that. And then we are going to move on to the posterior thorax. I might have you sit just on the edge of this. Yeah, perfect. We are going to inspect and palpate the posterior thorax, feeling for any abnormalities, including crepitus. Do you feel any tenderness here, Sarah?
No.
There's no tenderness. We're also going to palpate for respiratory expansion. I'm putting my hands at about the 10th rib. I'm going to ask the patient to breathe in, out. Respiratory expansion is symmetrical. Then we're going to palpate for tactile firmitus. I'm going to have you say 99 every time I move my hands.
99, 99, 99, 99.
Awesome. So there's no decreased firmitus. It's symmetrical on both sides. Next, we're going to move on to percussion. So I'm going to percuss in a ladder pattern. All throughout the lung fields. I hear resonance throughout. We're also going to percuss for diaphragmatic excursion. So I'm going to do is have the patient breathe in and hold it. So you can let go. So we're going to, I basically am percussing until the sound changes from resonant to dull. We would mark that here. And then I'm going to have you breathe in and hold it, or excuse me, breathe in and then all the way out. And I'm going to percuss back up until the sound changes back to resonant. And it's about 2 to 3 centimeters, which is a normal finding for diaphragmatic excursion. This is also a good time to percuss for CVA tenderness. Do you feel any pain? Perfect. So no CVA tenderness there. Next thing we're going to do is auscultate. Maybe take a deep breath for me. We're going to oscillate in a ladder pattern. All throughout the lung fields. Her breath sounds are clear and equal bilaterally. So then we're going to move on to the anterior thorax. I'll be turned back this way and sit down. So we're going to inspect and palpate the anterior thorax, especially feeling in those intercostal spaces in the ribs. Is there any tenderness or anything there? Perfect. So then we're going to percuss again. And I hear resonance throughout, which is a normal finding. Then I'm going to oscillate. And her breath sounds are clear and equal bilaterally. Then we are going to move on to, this is the time when we would do a clinical breast exam. We're not actually going to do that for today's exam, but I'm going to kind of talk through how you would do it and also how you can do a self-breast exam at home. So if you're doing a self-breast exam at home, you're going to want to make sure that you're doing it about the same time each month. That could be a certain day of the month or a certain day of your cycle. And you're going to want to stand in the mirror with your hands on your hips without your shirt on and visualize your breasts in the mirror. You're going to look for any asymmetry, deformities, dimpling, puckering, nipple inversion, nipple discharge, redness, rash, anything like that. You're going to want to do that in a couple different positions. You can do hands on your hips, hands up in the air, leaning forward and looking for the same changes in all those different positions. The next thing you're going to want to do is palpate. So in the clinical setting, we'd have the patient lying recumbent and arm behind the head. You can also do this at home, or a lot of people prefer to do it in the shower. And you're going to want to palpate with the pads of your fingers in a firm, smooth motion, circular motion about the size of a quarter. And you're going to want to palpate the entire breast. I'll have you lay down here. So you're going to want to palpate the entire breast, making sure you cover the nipple, the areola, the entire breast, all the way up into tail of Spence here, and making sure that you're palpating the supraclavicular, infraclavicular, and all the axillary lymph nodes. And you can do that with a couple different techniques. You can do it in kind of a wedge pattern where you start from the inside and work your way out. You can also do the vertical strips where you're kind of going in a zigzag motion palpating, and then you can also do a circular motion kind of starting from the nipple and areola and working your way out. You just want to make sure that you're covering the entire breast and staying consistent. And you are feeling for any lumps or nodules, especially those that are hard, mobile, or asymmetrical. So that's how we do a clinical breast exam. And then next we're going to move on to the cardiovascular and peripheral vascular assessment. So the first thing I'm going to do is I'm going to auscultate the temporal arteries. And I don't hear any bruit. Then we would also palpate and auscultate the carotid arteries, and we would do this one at a time to make sure that we are not impeding any blood flow to the brain. I don't feel any hues or thrills or hear any bruits. The next thing we're going to do is assess for jugular vein distension, looking at the external jugular vein. So I'll have you turn your head that way, and I'm assessing the external jugular vein. I'll have you lay back just a little bit more. So we have her about 30 to 45 degrees, and I'm looking to see if there's any obvious pulsations. I don't see any now, but if I did, I would kind of note where that pulsation is, find the sternal notch, measure out to where those two meet perpendicularly, and then measure that height, and that would give me kind of the degree of JVD there. So the next thing we're going to do is move down to the precordium. So I'm going to inspect and palpate the precordium, feeling for any heaves, thrills, looking for any obvious pulsations. We'd also locate the apical pulse at the mid-clavicular line, about the 5th intercostal space. Then the next thing we're going to do is auscultate So with auscultation, I would be auscultating with the bell and the diaphragm, both sitting and recumbent. I'm just going to show you the technique in one of those ways today, but we would do all of those ways during an exam. So we're going to auscultate aortic, pulmonic, Erb's point, tricuspid, and mitral. She has a regular rate and rhythm, clear at S1, S2 with no extra heart sounds, no murmurs, anything like that. Then we're going to move on to the peripheral vascular system, and I'm going to assess her pulses. We would do this bilaterally, but I'll just show you on one side. So we would do brachial, radial, femoral, right in this area, popliteal, posterior tibial, and dorsalis pedis. And all of those pulses are +2 bilaterally. We're looking at rate, rhythm, and amplitude. We already assessed her capillary refill, and then we're also going to look at her extremities and assess peripheral vascularity. We're looking at the hair distribution, if there is any edema, cyanosis, increased warmth or coolness, any non-healing sores, anything really that would indicate that there's decreased blood flow to the extremities or decreased venous return away. And then from there, we are going to move on to the abdominal assessment. So I'm going to have you lay all the way flat. And I'm actually going to lift up your... All right, so we are going to first start by inspecting the abdomen. I'm looking for any redness. I don't see any redness here. No redness around the umbilicus or any herniation. I don't see any obvious peristalsis or pulsations, and the contour is flat. So the next thing we're going to do is auscultate. So I'm going to auscultate in all 4 quadrants. She has normal active bowel sounds in all 4 quadrants, and then we would switch to the bell. We're going to auscultate the renal, iliac, and femoral arteries, listening for any bruits, excuse me. The femoral area. I don't hear any bruits there. So the next thing we're going to do is percuss. I'm going to percuss the abdomen in all 4 quadrants. I hear tympany throughout. The next thing we're going to do is percuss for liver span. So basically what I'm going to do is percuss down from the mid-clavicular line until the sound changes to dull, and then I'm going to continue percussing down until the sound changes back to tympanic. It's usually about 4 to 8 centimeters for a normal liver span. Next thing we're going to do is palpation. We are going to palpate first, doing light palpation, just feeling for any masses. Do you feel any tenderness? There's no tenderness there. Then we're going to do deep palpation. I am attempting to palpate the liver, the aorta, the spleen, and the kidneys on both sides. All of those are non-palpable, which is a normal finding. And then you can go ahead and sit up. I would also palpate the superficial inguinal nodes, both the horizontal and vertical groups. I'm not going to do that for today's exam, but that would be the last step in the abdominal assessment. Then we're going to move on to the musculoskeletal exam. So I am going to first start, we already kind of did this with the peripheral vascular assessment, but I'm going to look at the extremities, especially looking at hair loss, muscle mass, just looking for any abnormalities there. And then we are going to kind of start at the top and work our way to the bottom. I'm going to first start, and we do this all bilaterally, as I said before, but I'm going to start by inspecting and palpating the shoulders for any abnormalities, and then we'll have you do some range of motion tests. So you can put your arms up, back, out to the sides and behind your head, out to the sides and behind your back. So there's full range of motion there. I'm going to have you put your arm up like this. just like this. And can you like push against my hand and then pull? Okay, perfect. Then we're gonna move down to the elbows. I'm gonna inspect and palpate the elbows, feeling for the epitrochlear nodes as well. Any tenderness there? There's no tenderness. Then we're gonna do range of motion with the elbows too. So we're gonna go in, way out, rotate both ways. Perfect, and go like this. And then can you push against my hands and then pull? Perfect. So for the shoulders and elbows, she has full range of motion, 5 out of 5 strength. Then we're gonna move down to the hands and wrists. I'm gonna inspect and palpate the hands, the wrist, the fingers. And then we're gonna assess her range of motion again. I'll have you put your hands down, up, rotate, make a fist, put your fingers out, spread them real wide, and close them. Perfect. And then can you grip my hands? Perfect. So she has full range of motion, 5 out of 5 strength in her hands and wrists. Then we're gonna assess her spine. So I'm gonna have you turn this way and bend over and touch your toes for me. And I am inspecting and palpating the spine, all down the spine. This would be a good time to do a scoliosis screening, looking for any asymmetry in the spine. I don't see any here today, but you can go ahead and come up, and we're going to continue assessing for range of motion. You can lean back, hyperextend, then go side to side and twist. So she has full range of motion in her spine. Then we are going to inspect and palpate the hips, feeling for any abnormalities there. Then we're going to assess for range of motion again. So I'll have you kind of do like a all the way around and then like out to the side and forward and all the way back. If we just back straight like that, there you go. And then I'll have you lay down and so she has full range of motion. I'm also going to have you do a straight leg raise. Perfect. And then can you push against my hands and then lift your leg up and push down against my hands? Perfect. So she has 5 out of 5 strength in her hips. I'll have you sit back up again. And we are going to assess your knees. I'm going to inspect and palpate the knees. Then we're going to assess for range of motion. This couch is a little bit short here, but I would have you kind of out and in. And if you stand up, actually, you can go all the way back. Perfect. And then kind of rotate in and out. Perfect. And then I'll have you sit back down again and push against my hand and then pull. Perfect. So she has full range of motion and 5 out of 5 strength. And then we're going to do her feet. I'm going to inspect and palpate the feet. And then we're going to check for range of motion and go forward, back, in, out, do some circles. Perfect. So she has full range of motion. And if you can press on my hand like a gas pedal, you can put your heel to the ground. Perfect. So she has 5 out of 5 strength in her feet. And that concludes the musculoskeletal exam. Finally, we have the neuro exam. First, we're going to assess her mental status. You can tell that during this exam, she has been acting appropriately. Her appearance is appropriate. She has not had any problems with speech or language at all. And then we can move on to assessing her cognition. We already assessed her mental status, her orientation. We know that she's alert and oriented times 4. We're also going to assess her recent and remote thinking. Can you tell me, Sarah, what you had for breakfast this morning?
I had oatmeal.
Okay, and then what your high school mascot was?
It was a saint.
Okay, perfect. And then we'll also test your abstract thinking. So can you tell me a similarity between an apple and an orange?
They're fruits.
Okay, perfect. Then we're going to move on to thoughts and perceptions. I'll test your judgment here. If you were driving your car down the road and you saw a building that was on fire and there's no fire trucks or anything, what would you do?
I'll call 911.
Perfect. She's not exhibiting any flight of ideas. And then I'll also give you a couple words to remember until the end of the exam, and we'll see if you can recall those words. The words are car, dog, and fire truck. Okay, perfect. So then the next thing we're going to do is assess your neurosensory loss. We already kind of did this on the face. We're gonna do this in all the other extremities as well. I'm only gonna do it in a couple areas, but just know that we would do the arms, the hands, the feet, and the legs and the feet, excuse me. So I'm gonna have you close your eyes and tell me if you feel sharp or dull.
Sharp. Dull.
Okay, perfect. We would do that in all the extremities. We could also do hard and soft. Then we're gonna assess for vibration sense. I'm gonna have you continue to close your eyes, and if you can hold your hands out this way, and let me know if you can feel a vibration or if it's not vibrating.
It's vibrating. It's not.
Perfect, so we do that. In all the extremities, we'd also assess for pain. Can you I'll have you continue to close your eyes, and can you tell me where you feel this painful stimulus?
In my left arm. Right arm.
Perfect, so we do that throughout all the extremities. If her pain sensation is intact, we don't need to test for temperature, but if it wasn't, we could assess hot versus cold. And then we are gonna do 2-point discrimination. You can close your eyes again and tell me if you feel 1 point or 2.
1, 2. 1, 2.
Perfect, so we do that in all the extremities. Then we're gonna assess for stereognosis and graphesthesia. So first is stereognosis. I'll pretend you didn't see this item. I'll have you hold your hand out and close, and then close your eyes and tell me what object.
The key.
Perfect. And then we're gonna assess for graphesthesia. If you continue to hold your hand out, and I'm gonna trace a number in your palm, keep your eyes closed.
3.
Perfect, so no deficits there. Then we're going to assess her reflexes. We're going to do the biceps, triceps, brachioradial, patellar. It's kind of hard to do when the chair is so short, but we're also going to do Achilles. I'll come to this side. And just rest your hand on your phone, my hand. Perfect. And then the Babinski also. So all of those reflexes are intact and +2 except for the Babinski, which is negative, and that's a normal finding. Then we're going to move on to assessing cerebellar and motor function. The first thing we're going to do is rapid alternating movements. If you can go like this. Perfect. And then if you can take your finger and touch your nose and then touch my finger. Keep doing that. Perfect. And then we are going to move on to onto balance. Have you stand up and put your arms out and close your eyes. You can see there's no swaying there. Even if I go like that, there's no swaying. She recovers pretty quickly. Can you hop on one foot and then hop on the other? Perfect, so she does not seem to have any issues with balance. Then we're gonna do gait. I'm gonna have you walk across the floor, just normal walking. And then back, and then you can do on your tiptoes, and then heel toe walk. Perfect, so she doesn't seem to have any deficits as far as gait. And then finally for the neuro exam, can you remember those words that I told you to remember at the earlier in this exam?
Dog, car, fire truck.
Close. Dog, car, television. Yeah.
Television.
So almost there. But that concludes our neuro assessment as well as our head to toe assessment. Thank you guys so much for watching. Thank you to my patient here and my videographer as well. And y'all have a great day. Thanks.